Hello, everyone. This is Dr. Jeff Horowitz with Dentists in the Know, and welcome to Humpday Happy Hour with Dentists in the Know. Usually, we are the backstage pass for current trends, politics, and education for all of the dental community. But now we want to be that as well for you, all of the patients that are out there, and get you some of the best information we can as dentists. I am joined in this program, as usual, by two of the best people in the world, Dr. Chad Duplantis and Dr. Jennifer Bell. Together, we are the Dentists in the Know, or the DINKs, and we really see it as our obligation to not just bring dentists in the know, but to also bring you, the consumer, in the know as well. So with that, I will say that we are all dentists, we are all practice owners, and we are all educators. And our job is to bring all of you in the know. And tonight we have an incredible episode because one of the topics that comes up particularly this time of year when the kids are out of school is dental trauma and what you can do. So we're bringing you one of the best experts in the industry, Dr. Ryan Walsh, who is a root canal specialist, otherwise known as an endodontist, is joining us tonight. And together we're going to try to provide some great information for you. So guys, how was your week? And what excites you about this week's episode?
Go ahead, Chad. You've had a really busy week.
You know, it's been one of those weeks. It's always an honor to be a dentist, but this week, I don't know, maybe I was second guessing that decision a few times. It has been a really crazy week. It seems like I've been dealing with a lot of specialists this week. And it's all for the benefit of our patients, but just trying to be that quarterback and communicate and, kind of make sure that care is shared amongst the others and that we are communicating appropriately. Just a lot of behind the scenes stuff, but I'm glad to be here with you two tonight. So sorry, I had to vent.
Awesome. JB, how you?
Oh, it's been busy. This is that time of year. Everybody's got graduations and end of school year parties and stuff. So just balancing life. Our team as well have their own things that they're trying to make sure they get to and attend to while we're still trying to take care of our patients simultaneously. So always a busy time of the year, and kind of the schedule seems a little more fluid and things are moving a little bit more. But I feel already in looking at next week that things are starting to kind of get into the summer rhythm a little bit, which I think we all know is a little bit different. Just our patients are traveling. Our team is taking their time off as well. Maybe we should just be like Europe. They basically just shut down the month of August and then nobody does anything. And so it'd be really easier to schedule. I don't know. Maybe we're just like, August is done.
Yeah, that's what I need. I don't need a vacation. I need an August.
No, I know. And in Europe, I love my European colleagues and they have no problem taking time off, which I think Americans actually could learn a lot from. And, you'll send an email to someone during August if they live in Europe and it's like, I'm on vacation. I'll be back.
Holiday. I'm on holiday.
Yeah, I'll be back in 4 weeks. And then signed whatever. Like there's no, I'm sorry. There's no alternative contact point. It's just, I'm gone. Good luck with your question. I assume that it will be there when I get back. If not, that's really not my problem.
Yeah.
I'm gone.
And honestly, I feel bad when someone hasn't gotten to a patient's phone call in a day. Like, I mean, I just,
right.
It's we harbor such guilt and our work ethic. It's a good work ethic, but maybe it is, maybe it's not. But kind of freaky. And on another front, what I would say to all the patients out there is, please be kind to us when it comes to changes in insurance policies. That's something that as educators and as three dentists that have owned practices for a long time now, I don't think I've seen as many changes to insurance policies and regulations as I have seen in the last year, particularly for those of us who are maybe helping with medical insurance for things like sleep apnea or for traumatic injuries, like we may talk about this evening. And so just bear with us. I promise, as practice owners, we are doing the very best we can to make sure that you are all getting the benefits that you're entitled to. But it's really been a tough landscape to navigate here lately.
I'd
I
agree.
concur, without a
Yeah.
doubt.
Yeah.
I saw this awful good, I don't know, video on Instagram yesterday from a dentist. It was like 19 reasons why I quit dentistry.
Mhm.
And, 15 of it were things that dentists can't control. And how that sort of can be destructive to your mental well-being, emotional well-being. If it were just the relationship between you and the patient and your ability to do your job, regardless of the insurance, team members, lab, access to the types of things that you need at the cost that you can afford them, just, a variety of compounding issues. Maybe we wouldn't see quite the burnout that we see, but yeah. So it was a very interesting watch. I was like, number one, I felt really bad for her as a doctor because she had left the profession. And a lot of the reasons why she left was frankly because it didn't live up to what she thought it was going to be when she was in dental school as a young practitioner trying to build a career. So maybe it gets better at some point. Maybe some of the challenges will force the medical industry in general. It's really not just dentistry, but just force the medical industry in general to create beneficial environments for both practitioners and patients.
Yeah.
I think everybody would. I mean, I'm not. What should I say? This is like the Just for Men's Club or whatever. Like, I'm not only a provider, but I'm also a patient. I want the medical system to get better.
Yeah.
As much as anybody else does, for my own benefit of being a provider within it, but also as a patient and the struggles and challenges that are coming with that. So
let me throw an example at you both. And I know I want us to get to, we promised our audience trauma tonight, and we have, as I said, one of the best in the industry, Dr. Ryan Walsh, joining us tonight to talk about that. But just today, I had an experience. So for all of the patients that I treat for TMJ and temporomandibular dysfunction, we had a set protocol where they would come in, they would get a 3D image of their jaw, and I would do a very thorough history and exam. And at the end of that visit, I could give them a pretty good differential diagnosis. I think this will probably need surgery. I think we can probably take care of this with a splint. I think some dentistry might actually do the trick here. And then I was told by one of the companies that I decided to be a network with that they will no longer pay for the 3D image of the joint at the diagnostic visit, that I have to justify the 3D x-ray of the joint at that visit. So now I have to see the patient. At the end of the visit, they're like, well, what's wrong, doc? And I still have to say, I don't know. I am now required to take all this information when the information that I always need is to visualize the joint. I mean, you never go to the orthopedist and don't have an x-ray taken that shows you the joint. So I can't get all the information. And if I want my patients to receive the benefits that they're entitled to, I have to, from the point that I do the exam and don't have a good differential diagnosis. I mean, there's a lot more choices. And now I have to say, and oh, by the way, I need a 3D scan. The patient has to take off more time, come back, get another scan, and then we have to do the diagnosis. And then we have to pre-authorize the treatment. So it's really inefficient for us. It's inefficient for the patient, and it's actually more expensive for the insurance company because it always still goes down that path. There is nobody winning in that design, not even the insurance company, which can often be the case. So it's an interesting world right now. I wonder where it's going to go.
Would that be referred to as a conundrum?
Yes, I think that is an excellent word choice. And
Which is surprising.
did you look that up today?
Yeah.
Mm-hmm.
Yeah.
Yep, I did. Yep.
Do you have a dictionary in your bathroom and there's like a word of the day?
Yes.
Mm.
Conundrum was the word of the day.
Was it?
Yep.
That makes a lot more sense.
I could give you a couple other words, but they're not suitable
Yeah.
for live.
All right, Chad, we're not going to let you do that, but why don't you do this? Why don't you introduce our guest tonight? He's a great friend of yours and someone that you've worked with for a long time. So why don't you please have the honors?
It would be my privilege, but I'm going to have to ask you to bring him on because, as you know, I can't walk and chew gum. So I will talk and you introduce.
Consider it done.
Or you bring to the stage. So anyhow, this gentleman that's going to be joining us tonight is a world-class endodontist or root canal specialist, truly a innovator in the field of endodontics, someone that I trust wholeheartedly. I'm honored to call him a very dear friend. He and his wife and his 3 beautiful girls are very close to our family, and he lives very nearby. As a matter of fact, we play golf quite often. And I would have to say that I do beat him 99% of the time. And he has several shirts, hats, dollar bills that he has given me to prove that. But regardless, he is an expert in the field of trauma and dentistry and expert in all things endodontics. And my good friend from the University of Iowa, Baylor College of Dentistry, and Keller, Texas, Ryan Walsh.
Oh, wow. Yay!
And by the way, he is otherwise known as the Donk. Because we rely on him to contribute to this group, and he brings so much great information and great fun to our little party.
And he's like the life of the party. He's also not just my friend; he's everybody's friend. He's a friend of everybody he meets. So good to see you, Walsh.
Good to see you guys. Thanks so much for having me back on.
Well, so a lot of people might wonder why does a root canal specialist get involved with trauma? Where does that connection happen? If something bad happens, I'm calling my personal family dentist to see what we need to do. Why are you on this show to talk about trauma?
Oh, what a great question, JB. It's like you had this already prepped for us. Yeah. So, if ever there's trauma with a tooth, it's not just the tooth, but it's the orofacial complex, right? So I think there's a couple natural people you can call. I mean, you can call an oral surgeon. I would stress to parents to, yes, call your friendly neighborhood dentist, but call a dental professional. I mean, unless there's serious facial trauma, because sometimes you get the kids to the ER and the ER will kind of address the actual facial trauma or laceration, but they don't really address the teeth. And so in a case like dental trauma, where you're trying to focus on maintaining or keeping alive teeth or keeping teeth in the mouth, an endodontist is a kind of a natural transition for that. Right after the general dentist, a lot of times we're the next call, or, if Chad has trauma, a lot of times I'm on the horn with him within minutes of him getting the call from the patient to see how can we not only save the tooth and keep it in somebody's mouth, but equally, sometimes it's a matter of saving the pulp and we can keep the tooth alive, just depending on timing and the situation. So as an endodontist, that is the wheelhouse of my specialty, is treating the pulp and the dentin complex.
So with that being said, Walsh, why don't you share, there are actually 2 stories, one that's more recent than the other. But there was a story a couple months ago where a family called me. They were on vacation, blown out tooth, lower left. That's a great one to start with.
You're going to have to bring me back up to speed, buddy. I don't remember what case you're telling me about.
Well, that's because you were out of town and I had to deal with your partner, and then you handled it when you got back into town. But young lady was out of town, and not necessarily a traumatic episode, but remember the case where the face swelled up like a freaking softball, and the girl's like 12 years old.
Yes.
So
yeah, I mean, so in a case of, that again, it's not necessarily trauma from the sense we think of, getting hit with a baseball. I mean, 'tis the season for that. We've already been seeing those pour in the door. But a rapidly progressing infection, she woke up looking like she tried to eat a baseball. And in a case like that, a lot of times that's a tooth infection. I mean, it can be a host of other things. It's hard to diagnose from afar, but if it's a tooth infection, a lot of times it's just as simple as removing the source of the infection or doing a root canal for the tooth. If we can get inside the tooth and clean that bacteria out and get the source of the infection controlled, we can start that healing process pretty quickly. And sometimes we have to drain the abscess. Almost always we have an intraoral approach. Very, very rarely do we have to do anything extraorally, but most of the time it's just kind of on the gums up above the tooth. And it's kind of like popping a water balloon, get some of that, pus, get some of that crud out that's up there causing the pain and discomfort. And then we can treat it internally, inside the tooth rather, and get that out by starting a root canal for her.
Yeah. So I guess one of the first questions that I have is going to be a really simple question, but it's something that I think is important for parents and everybody to understand. I mean, of course, let's gear a little bit of this towards children, but let's say your child is out on the street and they're riding their bicycle and they hit the pavement or something happens and a tooth comes out. All right. What's the first thing that you recommend that a parent do when that happens?
I mean, the first thing you're going to do is panic and try to figure out where to go next. But ideally, if you're on site and you can find the tooth, right? So try to find and locate the tooth. That's important. We can put the pieces of the puzzle back together if you can just find the pieces. So if you can get that tooth and rinse it off, I mean, if you have a save a tooth kit at home, that's probably not likely unless you're a dental nerd like us having one sit at home. But even rinsing it with milk or saliva, rinse the contaminants off of that tooth. And parents, as hard as this may be, if you can put that tooth back in, you don't jam it back in, but nice, slow and steady, just kind of put it right back into socket. That's the best possible thing that you could do for your child to try to save that tooth. Get it right back where it came from, and then certainly call the dentist. But if you're a parent on site, whether it's, they're out in the front yard or at a neighbor's house or at the baseball diamond, try to rinse that tooth off with, again, milk, saliva, I mean, even Gatorade or something if you have it, and then put that tooth back into back into the socket. That gives that tooth the best chance of maintaining vitality and maintaining it down the road.
And one additional piece of information on that, Ryan, is when they try to reseat that tooth back in, that if they can close and bite back together, they have a pretty good validation that they've likely put the tooth back at least into a reasonable position.
Yes.
If you put it in or the trauma happens to the tooth and it's moved in a different direction and you can't put the teeth back together, you can't chew and kind of close.
Yeah.
Number one, it's a good indication the tooth is definitely not where it used to be. And two, that maybe in repositioning that tooth, you didn't quite get it all the way back into the socket. Again, not the end of the world. To your point, getting on the phone with a dental professional as quick as possible. Time really is important in these particular cases to at least triage and figure out. And one additional caveat I would say is that when patients call, I immediately ask them to go ahead and send me a picture because everybody has a different interpretation of what they think has happened. And some understand that breaking the crown part of the tooth is one segment of the whole tooth. Some believe that is the whole tooth, right? Yep. So I always ask for a quick picture so we can immediately start to triage who all I need to get involved in that particular call and make some quick decisions. Is this a right now problem or a tomorrow problem so that we can manage the patients better?
Yeah, absolutely. To your point, JB, it's like, is this a tomorrow problem? Sometimes if it's just, a crack in the enamel and the pulp's not exposed. It just may be
Yeah.
sensitive to cold. Maybe it's a let's get on some ibuprofen or Tylenol. Let's settle down a little bit and get home from the ball game, and we'll see you bright and early tomorrow. Versus, hey, my tooth was in my hand, and now what the heck do I do? That's kind of a, it doesn't matter whether it's Sunday night after family dinner or not. That's a we need to see you right now problem.
Yeah,
Now,
for
Ryan,
sure.
would you also add that if the patient is able to look, let's say the tooth is just broken in half, and the parent, because we want to assess the situation, and if they see a pink spot or a bleeding spot, that would also then become urgent, because we may have the ability to protect that nerve from dying. There's no guarantee that we will, but certainly if we see an exposure to that nerve, the sooner we treat, the better. And would you agree that they should, if it's possible, to bring along the piece of the tooth that's broken away to do that as well?
Yeah, Jeff. I mean, 100%. Again, if any of the pieces of the tooth or the tooth itself that come out, if you can bring those back to us, not only does it help with aesthetics at the end, trying to restore things, but also it gives me a better assessment of where things were and what type of trauma was present. But yeah, parents out there, if your kiddo breaks a tooth and you can look at it and the tooth itself is bleeding, not the gums around it, but a little pink spot bleeding from the tooth, that's the pulp. That's the nerve and the blood supply of that tooth. So that becomes a right now problem, because if we had the endodontic community, if we can get to that pulp within an hour or two, we can most likely save that pulp. In other words, keep that tooth alive, very predictably moving on down the road. Conversely, if that tooth is bleeding, there's a little pink spot, and we don't see it until tomorrow, the prognosis of that tooth is just steadily declining, because now we have bacteria to contend with, right? We have all that bacteria in your saliva that's now getting up and irritating the pulp and possibly getting into it, starting to cause necrosis or causing it to die off. So the sooner we can get to that, the more predictable any treatment outcomes are, not just maintaining the tooth, but maintaining the nerve inside the tooth.
What would you suggest if they find the piece of tooth? I know you mentioned a number of substrates that we could soak it in. What would be your go-to if somebody were to find a piece of tooth on the ground or find a whole tooth on the ground and they're just averse to putting it back in? What would you suggest that they soak it in?
Well, if you're at school or sometimes even at a ball field or a gymnasium, they'll have a save a tooth kit. They're a little,
I have no idea what the hell that is. So just go ahead and tell us what's in it.
Okay. It's a Hank's Balance Salt solution. It's a kind of a powdered saline, and you put your tooth in there. And the reason why it's valuable is not only it gives you a little case to hold the tooth, but it also preserves the cells that are around the tooth, and then ultimately makes it more predictable to replant and increases the prognosis long-term to keep that tooth. But again, if you're not in one of these ideal environments or around a tooth nerd like us, I mean, you can use milk, you can use saline if you have something at home, if you have some saline sitting around at home, even your own saliva. That's a great alternative. I mean, just worst case scenario, just put it in your vestibule. You just kind of put it down in between your lip and your teeth, and
like Copenhagen.
What's that?
Like Copenhagen.
Yes, exactly like that, Chad. People in the South will really identify with that.
Yeah.
Put it in there, make it look like
between your cheek and gum.
Yeah. But
yeah,
anything we can do to keep that tooth moist is better than the alternative. I mean, tap water is not great, but if we let that tooth dry out, especially more than an hour out of the mouth, the chance of keeping that tooth, even if we put it back into their mouth, the chance of that tooth surviving long term is dramatically lower. So keep it moist. Ideally get in within an hour. That's not always possible, but if you can't get in within an hour, we need to keep that tooth moist the best we can to help preserve all those cells that are around the tooth. That way it'll reintegrate back into the mouth and the oral environment.
Love it. That's fantastic.
You go ahead, Jeff.
No, JB, you were next. I like to keep the order going.
Oh, I see. Well, and I was just going to say for patients that have experienced this particular issue, sometimes we can get it put back together. And sometimes if there's bony fractures or other things that are happening around it, the dentist may be somewhat limited in their ability to reseat that tooth back in. especially if they're unable to get you numb for some reason, either cooperation, if it's a younger patient, or the facial trauma is so significant that it's just really hard to find a landing spot to get you numb to kind of put things back together. So generally speaking, they're sort of in triage mode to do the absolute best they can to stabilize the patient until things have calmed down, and sometimes just emotionally have calmed down so that they can come up with a plan B. The one thing I will say, having done quite a few of these trauma cases and meeting patients over at the office, it always looks way worse than it is. And that's simply because soft tissue and mouth tissue tends to swell and get crazy, gross looking really fast. And so a lot of times your perception will be that things are really, really bad. And it's just because it just blows up and swells really, really quickly. And it's amazing what 24 hours will do to calm the tissue back down and how fast things actually really heal.
And it bleeds so much. I mean, everything
so much
in the mouth, especially, it's so vascular. And JB, also to your point that, if the tooth comes out, the tooth didn't just slide out of the socket, right? Usually the bone that houses and supports your teeth, which is right under the gum tissue, usually that's broken at some level. So mom and dad, take that tooth and try to replant it if you can. But if it doesn't slide in how you think it's going to, just keep it moist and get into us. Because again, the sooner the better. But also what I've also found is the sooner we can get to it, sometimes there's this like big adrenaline rush from the kiddo where they're almost like self-anesthetized. They're so adrenaline pumped at the time that you can put it back in and it's not necessarily painful, right? It's
right.
Like they're already sore from the trauma they just incurred. So it's like you can kind of get it back in there, and they're no worse for the wear until they can get into this.
Yep.
So here's a quick question.
Chad just skipped right over me. He knew I had a question.
I saw it.
Did you see what just happened there, JB? Do you see how I'm just really unimportant to Chad?
I did.
Yeah. Okay.
Go ahead, Jeff. I'll wait.
Oh, okay. No, really.
No, really. Go ahead.
Guys, age before beauty, right?
Yeah. So that would be Jeff. Go ahead.
I lose again.
Curses.
No, the other point that I was going to make is I think it is important for parents to also understand from their end what is a right now problem versus what can be handled potentially the next day. And one of the other big concerns is we obviously see the tooth that has been traumatized. It's either broken or it's avulsed, it's come out of the mouth, but we don't necessarily see the trauma to the surrounding teeth. And so a really good assessment, and JB alluded to this earlier, is if before you put the tooth back into its place, if the patient or whoever has lost the tooth or broken the tooth, if they can't bite into their normal bite, there's a really good chance that they've sustained a fracture to the bone that surrounds the teeth as well. And there might be more teeth involved, even though it may not appear to be the case. And so even if you're able to get it in, that's something important to let the dentist know, and to ask your child or who has ever sustained the injury is, are you able to fit your teeth back together again? Because if the answer is no and they're banging into other teeth, there's a good chance that they've sustained a luxation or a fracture of the bone around the teeth. So that also needs to be addressed. Wouldn't you agree, Ryan?
Yeah, totally, Jeff. You're absolutely spot on. Chad, thanks for letting Jeff talk, because that was a really good point.
Yeah, well, see, I make good points. The thing is, you know what you're going to get from Chad? What flavor ice cream did you order at lunch today? That's what you're going to get from Chad.
But one other thing to tag on to that, Jeff. not to dog pile on Chad here. Is yes, not only can they touch things together and whatnot, but we always see the worst thing, right? And we're very easily to get tunnel vision, not us as dentists, but us as parents as well, right? So if you get hit with a baseball and a tooth pops out, it's like that's blunt force trauma. So one tooth may have taken the brunt of the force, but everything else also was impacted. So one may have been the epicenter, but there can be other problems as well. And sometimes those problems don't rear their ugly head for, several months or even 10 or 15 years down the road, when a tooth spontaneously necroses. So mom and dad, just be aware that we're trying to test other things as well to make sure that not only the tooth that was mostly damaged is getting back into good health, but also that the others are doing okay. Or if they need treatment as well, we need to identify that early, again, just to help prevent anything major from occurring down the road.
Chad, did you want to say something?
Is this working? Can you hear me? Okay.
Sounds like it is.
No, question that I have, and this is actually for, parents of children, but it's also for young dentists as well. One of our first thoughts when we do reimplant or place that tooth back into place, as a young dentist, we might think we need something fairly rigid to hold that tooth into place, whereas it's almost the exact opposite. Fishing line or something like that might be the best to connect those teeth together to the adjacent teeth. So
yes,
what would you suggest? And this, like I said, this goes to a dentist, but I think that the theory behind it needs to go to the parents as well. What would you suggest that the dentist ligate those teeth together with, or secure that tooth in place with, when that tooth is reimplanted?
Yeah, that again, another good point, just kind of moving down the continuum of treatment. It has to be semi-rigid or flexible. It can't be super rigid. So I've heard some people using like Ribond or something, but that sets hard. You don't want it to set hard like a cast. So it's counterintuitive, because if you break a bone, you want that to be set rigid so that bone reapproximates and heals. But a tooth is surrounded by a ligament. And so it's really important that we're trying to not only maintain the tooth and the bone health, but also that interface between the two, the ligament. And so if we use a semi-rigid splint, fishing line, cut a 4 or 5 pieces of light fishing line. There's also this really, for dentists out there, there's this really cool stuff from GC, and they make it, and it's supposed to be a temporary bridge material, but it's flexible. And this stuff works awesome. You can put a few dollops of composite on the teeth, and you just literally cut it and lay it right over and then cure your composite, and it's still flexible. So really easy to use in that way. Sometimes fishing line's hard to get all your strands lined up, but you have to have some type of physiological movement. Otherwise, what'll happen is you'll increase the likelihood of ankylosis. In other words, it's a use it or lose it thing. So if that ligament isn't moving or isn't being used at all, even during repair, it's going to go the opposite way and you're going to lose it. It's going to ankylose, and that tooth's going to basically become concreted into socket and won't be able to move.
I think one of the questions that will frequently come up is, do I go to my dentist? Do I try to find a local dental professional if I have facial trauma, or do you go to the ER? And I think, how do you, as a patient, how do you discern? Maybe you have a relationship with a local dental professional. Maybe you're traveling and you don't have a relationship necessarily. Do we have a couple key points that we could mention that would say, if these few things have happened, you need to pursue the ER versus maybe just going to see your community support system?
I mean, yeah, that's a tough call, JB, because if you're out and about, or you're traveling for sports, or you're traveling with family during the summer, honestly, just getting in somewhere and getting triaged is great, because they're probably going to if you go to the ER, they're probably going to take a head and neck radiograph or a CT scan, because there could be other types of trauma that are going on as well. I mean, it may not just be teeth. So it could truly be, broken zygoma or orbit fracture, or it could be a host of other things. But if you have a tooth that's popped out of socket, or avulsed, or fractured, something that's true dental, I'd try to contact a dentist, even if it's an after hours emergency dentist. A lot of times, as the endodontist, we're primarily a referral based specialty. So if you aren't a patient of network or a friend of ours already, I'm probably not the first person you'd call on a Friday afternoon. But just getting into that emergency dentist, getting that first point of contact, they can then refer you to an endodontist or call that person because they for sure have a relationship with an endodontist or an oral surgeon or somebody that can help move to the next step.
Yeah, and the only additional piece of information I would say is that unless it appears life-threatening, which would indicate that you really need to be seen in the ER, the unfortunate issue is that many will go and wait in an ER for hours. And sometimes you're going to get a faster response time from your local doctor or dentist that's in, even your pediatrician that's in your community that is inclined to respond to these types of calls and requests after hours, at least to help triage to decide, is this a case that needs to go on to the ER? You know, if it doesn't appear to be life-threatening, when the accident happens, you know, they're coherent, conscious, those types of things, then if they have that discernment to be able to decide, should we contact a local person or the ER? Because the ER is going to be a place where you may find that you wait an inordinate amount of time to be seen.
True.
Well, and JB,
All
to
for
piggyback
no
on
resolution.
Yeah.
to piggyback on what JB said is that if you do happen to go to an emergency room, most ER physicians are not well trained in dental trauma. So what's going to happen is basically it's going to take a long time to get back. Then you'll be seen by the ER physician, you'll be triaged, and then they might put a call out to an oral surgeon who will definitely not be on site unless you happen to be at a teaching hospital where there is an oral surgery residency going on there. They're going to have to reach out to an oral surgeon who may be off site. You very well could lose your window of opportunity. So, I really think that the best thing is to try to make that contact with a well-known and established contact in the dental profession. And this is why dental relationships matter. They really do. It's, establishing yourself with someone that you feel comfortable will answer an emergency call, I think is so critical. I mean, I think there's still room for that kind of dentist patient relationship. And I think your chances of a positive dental outcome will be way greater if you are able to circumvent the emergency room. Not that you will necessarily get bad care in the emergency room. And if your dentist really believes that this is something that should be an emergency room situation, or if there's profuse bleeding or something that really makes you feel that someone is in imminent danger, by all means, please utilize the emergency room. But for most dental trauma, I would say your chances for a positive outcome will actually be better if you're able to circumvent that.
Chad, I think you muted yourself, buddy.
I'd have to agree. And Jeff, I'd have to say that earlier you asked a question, and I just want to let you know the flavor is here. There's cream in the middle. It's actually a fantastic little popsicle here.
How'd you get a popsicle?
That's the flavor of ice cream for the night. So there you go. Kiss my rear end.
No one offered me a popsicle.
I want a popsicle.
So there you go. It's not ice cream. It's a popsicle.
Okay.
But here, Walsh, you want one? You're just right across the street.
Thanks, buddy. I'll stop over afterwards to have a popsicle.
There you go.
Come on, dude. Hey, so
how adulted.
One of the things that I wanted to bring up, Jeff brings up a really valid point. If you go to the ER, unfortunately, it's not a matter of them not being competent. It's just them not really knowing dentistry. And I think that all of us have our rules within our practice that we're going to, we always, and I can speak for all four of us, we're always going to answer our phone. And the majority of us have our cell phone numbers on the answering machine at the office to get a hold of us. But, I have a rule of thumb that I've followed for a number of years, and that's if it's a child or if it's a front tooth, I'm always willing to go in. Mm-hmm. If it's not a true dental emergency, then we're going to do our best to, appease you and get you in first thing that we can the next week. but we've got to do a job of triaging, and we do have families as well. But I mean, I've gone up on Christmas Eve. I've gone up, on various holidays. I don't know about you all, but it seems like every stinking year, the holiday that gets the most emergency calls is the 4th of July.
Mm-hmm.
It's like you can be headed out of town to go shoot fireworks with your friends or whatever, and you're going to get a call. Inevitably, 4th of July is always the one. But dentists do have a compassionate heart. They treat patients a lot differently than most other professions. And we're going to at least make sure that you're in the best capable hands possible. Now, if you don't have a dental home, I know in our area, we have a new concept that's going on that's actually pretty fantastic for patients. We have a 24-hour-a-day dental emergency clinic. There's 2 of them within the area. And it's been kind of a lifesaver for me if I'm out of town and I'm having a hard time and I really want that patient seen. I feel confident that I can send them there and they're going to get taken care of and they're going to get sent right back to me. So, just please be understanding of your dentist. Please be understanding of their circumstances as well as yours. But know that, the vast majority of us do have a heart, and we're going to do what's ever in our capability to get you taken care of.
Yeah. And totally that. Absolutely. And it's, again, never to disparage my medical colleagues. That's never. How's that popsicle, Chad? Never, because they are so knowledgeable and skilled in so many things that I could never dream of doing. But it's like the teeth. Yeah, I think most medical professionals don't like to deal with the teeth. Everything around it, but as soon as you get to the mouth, they'd prefer to punt, and that's great because that's right in our wheelhouse. And again, I would encourage everybody to call your dentist, but I don't want to speak for everybody out there. It's like, I don't know how often everybody else answers their phone, or, if, on a Saturday night, if somebody calls, are you going to meet them up there? But to piggyback on, was it Jeff or Jennifer? It's like, send me a picture. I mean, there's been a handful of times I've gotten a call from a general dentist, and then I immediately talk to the patient. There was one a few months ago, Chad, we were talking on the golf course. I got a call at 10:30 at night. Their kid tumbled down the stairs and fractured a tooth, and there was a little pulp exposure. And so it's immediately get on the horn with mom and dad. And it's like, okay, you and the dentist are already en route to the office. Here's what I'd recommend. So don't hesitate to reach out to your dentist. I mean, within reason, we're always going to try to get back in touch. And, especially those of us, and I'm an emergency-based specialty. So we deal with this all the time. Don't hesitate to reach out.
And, just a word of the wise for parents as well, when we're talking about, kind of how to triage this from a parent's perspective or from just a layperson's perspective. If you have something that you think involves the teeth or the jaws and you have to go to the ER, try and find somebody with an oral surgeon on call or an ER with an oral surgery residency.
One of the things I was going to have you discuss, Ryan, is once the trauma happens, once we've gotten through phase 1, which is triage, managing soft tissue bleeding, swelling, pain, and then whatever we can do for stabilization to get us through the next window of time. Let's talk about the journey, because I think a lot of people, you correlated this trauma to bone trauma, which I think is something that folks are fairly familiar with. If you break an arm, I think almost everyone could pretty much tell you what they think will happen, right? They'll take an image of it, figure out where the fracture is. If it's truly fractured, stabilize it, put it in some type of rigid protection. You do that for a period of time, and then typically life goes on, and you probably never really think about that bone again. Teeth are somewhat different. You've got both the short-term management, which typically is a 3 to 6 month period of time in which we're managing and watching the trauma. And then you've got the long-term, what's going to happen to the tooth in the next year and 30 years from now as well. So can you talk a little bit about, let's talk about short-term management first.
Okay.
What should patients expect if they have a traumatic event that has compromised the tooth, or at least the doctor is concerned about the longevity and health of the tooth long-term? What can a patient expect?
Yeah. So I guess let's approach this from kind of 2 different angles, because in trauma, I always say that something has to give. Either the tooth breaks or the bone breaks.
Right.
Not often do they both happen. So if your tooth pops out, avulsion, the bone broke. But if your tooth cracks, many times it's the tooth that broke and not the bone. So from, let's say, an avulsion standpoint, we get that tooth back in, you splint it. And if it's a kiddo's tooth and the root tips are wide open, there's a fair chance that that thing will spontaneously reinnervate or revascularize. I hate to promise the moon and come up short. I always try to paint a realistic picture that if you can get it back in within an hour, there's a realistic chance that that tooth regrows the nerve and becomes a relatively normal tooth. Now, with that said, I would say the chance of that tooth needing a root canal at some point in that person's life probably just went up exponentially. But again, that's kind of a hard thing to predict. If it's an adult tooth with a closed apex and it came out and went back in, yes, we're going to get it splinted back together. We're going to get you feeling better. But ultimately, that tooth's going to need a root canal at some point. So mom and dad, don't be concerned if your tooth or if your young person's tooth needs a root canal, because a tooth with a root canal will still move with braces, just like any other tooth. It'll still aesthetically look like the other teeth. Modern dental materials or modern endodontic materials specifically don't discolor teeth. So that's a question I get all the time is my tooth going to turn gray over time? No, it shouldn't. If we get inside the tooth and use color stable materials, your tooth should look and function just like normal. It's just going to be something you have to be conscientious of because, yes, it's going to be slightly weaker than the adjacents, but overall, it's going to be a good, functional, aesthetic, healthy tooth long term. And then it's important to, again, kind of going past this 6 to 12 month mark, JB, to continue to monitor these things. So don't get in the habit of just saying, hey, it feels good. All my teeth feel fine. I'm probably okay. No, we need to monitor these teeth more than we would, your every 6-month checkup, or more than your normal teeth is what I'm saying, because the teeth next to it that also sustain trauma could need treatment down the road. Hopefully they don't, but they might. And the earlier we can catch that, the better.
I'm going to play devil's advocate and ask you a question, Ryan, because I know, as you know, there's information on the internet. Did you know that?
On the interweb, really?
On the interweb, yeah. Now, on the internet, there is a lot of information, and there are a lot of threads, and one of the things that I see is people talking badly of root canals, like we shouldn't be getting root canals, we shouldn't be doing root canals. I would love for you to please talk to this point and say, listen, keeping a natural tooth is still a better option than removing it and taking our chances on an implant, which is not a 100% slam dunk, like a lot of these articles and other people would have you believe in what they're writing. So could you maybe dismiss some of the myths about root canal and make people feel a little bit more comfortable about what that process is and the fact that you can go on and lead a long, healthy, happy life with a tooth that's had a root canal?
Yeah, that's a question we get all the time. I mean, I'm an endodontist. I'm a root canal specialist. I do root canals all day, every day for my entire career. So I guess I would first start off by saying that if I felt like I was doing something that was intentionally harming somebody or putting them at adverse risk for another complication, I couldn't go home and sleep at night. I mean, I've done these procedures for my family members, for my father-in-law, for my uncle, for my parents. So yeah, just starting off with the basic concept of, we're trying to do something good for somebody. I'm not trying to do something I think may potentially cause harm. But beyond that, boy, we have overwhelming science, not just speculative science, good hardcore science that says root canal teeth are good, healthy teeth. I mean, let's think about it at a fundamental level that the nerve or the pulp inside your tooth, once it's an adult tooth, only functions to feel hot and cold. I mean, the reality of an adult tooth nerve is that it only feels hot and cold. So a tooth with a root canal, the only deficit it truly have is that it doesn't feel hot and cold. The nerve is so critical for the eruption and the development of the tooth. But the analogy I always use, it's like the old Tom and Jerry cartoons. When Tom tries to mousetrap him, Mousetrap Jerry and he traps himself into the corner of a room and he can't get out. It's like that's what a nerve does inside of a tooth. It just kind of gets stuck inside this hard tissue. And so just because the nerve goes south because of trauma, because of decay, something like that, a restoration or something like that, that doesn't mean the tooth from a structural component's bad. It just means one segment or the soft tissue's going south. And so we can replace that soft tissue. And today we have bioactive materials that are stimulating the body to heal up against the tooth. We're not just plugging a hole, right? I mean, we're using similar things to bone cement and stuff that people use in artificial joints and in bone fracture repairs. I mean, we're using very similar type of materials inside of our teeth these days. And so I never want to get into the counterpoint with a patient of, I'm not here to change what you believe. That's not my goal. That's not my job. But let me lay out the facts for you is that we're doing how many millions of these every single year. And there's, by and large, there's no adverse impact, right? We're prolonging somebody's tooth, the life of their tooth. And if that patient's digging in their heels and saying, it's going to cause some issues, sure, go ahead and have it extracted. But what I would say is the longer we can keep the tooth, the more aesthetic, the will be long term. You know, the longer we can keep a tooth into adulthood, the more growth and maturity have developed, and the better aesthetic for that implant. So even if it's a short term fix to keep this tooth into adulthood, all the better. And we have so much science to back that up. And if anybody has any questions or concerns about that, go to aae.org and look that up. They have a bunch of supporting evidence that I just don't have time to get into tonight, but the American Association of Endodontists has all of that information. It's just a quick away there, Jeff, speaking of information on the internet.
Oh, he's muted. You're muted. And obviously speaker's
He
not working
obviously
either.
doesn't realize he's muted. But it's been a fantastic conversation, Jeff. We're really enjoying it.
Look at him. He's so cute, just talking to us.
He's about to eat his microphone.
Yeah.
Still muted, Jeff. Yep.
Yeah. This is the most uncomfortable muted experience I've ever seen.
And you know the worst part is that none of us can read lips.
No.
Why can't you read my
There he goes. There he goes.
I had a cough earlier, so I had to mute. I will end my comments with our friend Paul Goodman actually had one of my favorite phrases that I've heard, which is that an implant is not a substitution for a tooth. An implant is a substitution for not a tooth. So it is in your best interest to try to hold on to the natural structures if you can. And so I was glad you were able to clarify that, but I'm sorry about the mute.
Yeah.
Let's talk about what vitality testing is and why that's a part of trauma. When patients come in and they've had a traumatic event, they might notice that a dentist uses cold to test whether or not a tooth is alive. They might tap on teeth. They might feel around in the soft tissue structure. What is the purpose of vitality testing or testing to see if a tooth is alive or not alive? And then what's that natural cadence of monitoring that tooth over the next 3 to 6 months to start to make decisions about whether or not a root canal would be beneficial to the patient?
Awesome. Yeah, JB is asking all like the good, pointed, in-depth questions, guys. You need to pick it up. Quit worrying about your popsicle flavor over there. All right.
It's not the first day I've carried the load. It's just not.
JB, it's a heavy load.
Is my mic working?
Yeah. So it's really funny that we call it pulp testing or pulp vitality testing because we've been doing the same tests for like 70, 80, 100 years, percussion. So we tap on the tooth. Sometimes we'll push on the tooth or wiggle or around the tissues. Oftentimes I'll have you bite on the tooth. And then the last one I usually do is cold. And let's go in reverse order, address cold first. And the reason we test with cold is because that, what we talked about just a few minutes ago, the nerve inside an adult tooth functions to feel hot and cold. So if I touch cold on a tooth and you feel it, And it's non-lingering. You touch it and you're like, ooh, that's cold. And it goes away within a couple seconds. That tells me the nerve inside's alive and kicking. That's what I want to see. Conversely, if I test a cold and it's just shooting pain, uncomfortable, that could tell me there's a lot of inflammation built up and your nerve or your pulp's unhealthy. And then if I test cold and you're not feeling a darn thing, nobody's home. The nerve may have died off. Now with trauma, let me add a little caveat in there. Sometimes after trauma, the nerve in your tooth is kind of stunned. And so even if I test cold on a tooth that later turns out to be perfectly normal, sometimes right after trauma, it doesn't feel that. So our studies show that we can give it up to 3 months, depending on the circumstances, but 3 months barring any other signs or symptoms like discoloration, infection, swelling, bone loss, 3 months for that tooth to start to respond to cold again. So if I test your tooth and I see you back in a couple of weeks, usually I'll see you in 2 weeks and in 4 weeks, and then we'll go out to monthlies up until 3 months. And the reason being is that I'm just trying to gather data points and say, hey, your tooth was alive in the middle, or your tooth was not responding in the middle of May, but now we're the middle of June and your tooth is responding. Well, perfect. It's healing the way Mother Nature intended it to. So that's a good thing. So we'll continue to test until we can conclusively prove, yes, it's going to heal, or no, it's not. Now, the percussion and the biting, that's usually to determine, is there cracks or fractures in the teeth? Or how are the supporting tissues? Are the bone and are the ligaments around your tooth healthy? Have they been damaged? And sometimes even tapping on the teeth, just the sound of it, we can tell, is there something wrong with the ligament on your tooth? So each test gives us a little piece of the puzzle that we put together, combine that with x-rays, and then kind of come up with this whole diagnosis of what's the tooth looking like? What's the long-term prognosis going to be?
It's crazy. I had a patient who had a traumatic event as a kid, long before he became a patient of record in our office. And as a young adult, he had a 2-year-old toddler and he bumped that same tooth, which had never had a root canal, but definitely had, a composite repair where the dentist had repaired the tooth many years ago. And he re-injured it on a toddler's head. They were goofing off. And you know how those little kids with the giant noggins, they throw it around and then it bumps everything in sight. And it got his tooth. And within 24 to 48 hours, it went into this massive eruption process, or like it erupted into this huge infection. And so I always try to caution patients as well to say, trauma teeth are just weird. They are very weird. And once that trauma has happened, we're going to deal with what's going on eminently to get it stable and, to try to protect it from an aesthetic perspective, et cetera. But there's sort of this sleeping dog scenario where anything could poke the bear and wake it back up in a future time period. That can be orthodontics and tooth movement. It can be a re-traumatizing of the tooth itself, and what might be under normal circumstances not overly traumatic, but for a tooth that's already had trauma in the past, they can develop that. And the third thing that we see that maybe we can just spend a few minutes closing the show on is the long-term issue of resorption, and whether or not the body decides whether or not it wants to keep the tooth in its current position or not.
Yeah. Resorption is one of my favorite topics to talk about because it's something that we just don't know a lot about, right?
Hey, just for our audience, will you define what resorption is?
Sure. A resorption, very simply, is just a loss of hard tissue. But the resorptions, let's go back to our ice cream references here. Resorptions like Baskin Robbins. I mean, it comes in a bunch of different flavors. We know. So, for instance, when a baby tooth root kind of dissolves as the permanent tooth's coming up, that's a type of resorption. So, resorption is not all bad. That's physiological resorption. But the type that we're specifically referring to after trauma, most often, at least in my experience, is cervical resorption, or some type of resorption where the body literally is starting to eat away the tooth, right? It almost is like part of the tooth was damaged and the body sees it as a foreign object and starts to dissolve it. That's not exactly the mechanism that we're proposing, but similar. And so, we went back earlier, we were talking about how fast we can get the tooth back in or treated, because time is truly of the essence. And we know that to be very true with the predictability of resorption. So if we can prevent resorption from occurring, the long-term prognosis of these teeth structurally is really good. Again, they may need a root canal throughout the life to get it, to get it along. But if we can keep that extraoral dry time less than an hour, in other words, if your tooth isn't dried out, you're getting it back in socket, you're putting it in some type of fluid to transport it to the dentist and get it back in ASAP. Or if your tooth is fractured and you're getting into the dentist to help preserve that pulp faster, the prognosis of the tooth goes up, the chance of resorption goes down. So with avulsion, or when your tooth is knocked out, the faster we can get the tooth in, the less likely you are for resorption. Because once resorption starts, it's hard to get it to stop, and it's very unpredictable. A study that our office and my colleagues over in Dallas, we published a study a couple of years ago that showed that people who've had braces and people who've experienced trauma have about 2 times more likelihood of developing resorption. Now, it's not causative. It's not saying that just because this happened, this will happen. But people who've experienced those have a higher likelihood of developing resorption.
Mm-hmm.
So we know that if you've had trauma, you have a higher likelihood of developing it. Not only is it something we need to be more cognizant and aware of, but it's something you as the patient should bring up to new dental providers as you move throughout your life. If you move away to college, if you move on to a career, let your dentist know that you've had trauma so that they can take the appropriate radiographs to help monitor this for you. Because the earlier we can intervene and catch these things, the better the long-term success of your tooth will be.
And before we close out, can I just want to ask one more thing, and any one of the three you can answer. How important do you think three-dimensional x-rays, or what we refer to as cone beam CT x-rays, which are like CTs that you would get in the hospital, only much lower radiation, but they give us a 3D depiction of what's going on in the arch versus the old panoramic type image? How important is that type of an x-ray to the process of a good diagnosis and prognosis for a patient who sustained a traumatic injury?
B.
B.
Oh, exponentially. That gives us so much more information on what type of injury, right? Is it tooth? Is it tooth and bone? Is it just bone? All of these things are treated with different nuance of dental treatment. As the patient, it may seem like it's all the same, but there's different splint times. There's different materials we'd use. There's different ways we can reapproximate or set the tooth. So there's a whole bunch of things that CT allows us to see nowadays that dramatically impact my treatment. And most of the time, it allows me to be much more conservative because I know specifically what I'm treating and where I'm treating it. So I don't have to just treat just in case this is like, just in case X, Y, or Z. I can treat because I know very specifically tooth number 8 had trauma and 9 is not impacted at all. So from my perspective, every trauma case gets a CT in our office because of
and I wanted the general audience to hear this. I wanted the public to hear this because I think that this is an important piece to diagnostics that patients should now be demanding from the dental population. Listen, if your true and trusted dentist doesn't have a CBCT yet at this point, I would still take their advice and let them send you where you need to go, if you've got that kind of a relationship. But this technology really has helped us in terms of a solid diagnosis and prognosis. And so it is something that I think patients should be asking for in their dental practitioners is, do you have any kind of 3D imaging?
Yeah, we had a case not that long ago, actually, of a young girl that fractured a front tooth, and it fractured in 2 ways. It fractured horizontally across, but it also had a vertical fracture going up the root. Yeah. And had it not been for the CBCT, we wouldn't have been able to triage correctly what we needed to do that night versus what we were going to have to do the following day. because we could see exactly where the fracture went. So we had a really good prognosis for being able to save the tooth. When you just looked at it or just took the flat normal intraoral radiograph, you couldn't see the vertical fracture depth. And I couldn't physically feel exactly how far it went down. But once we took the three-dimensional image, I could see exactly where the fracture line sat and whether or not we were going to be able to get her comfortable that evening and also go ahead and remove that segment without causing additional issues. And anyway, from a diagnostic perspective, we had so much more information we were operating with to start to make good decisions for her long-term well-being for that particular tooth. If you only had the intraoral photo and the intraoral image alone of that flat radiograph, I don't think we would have been able to do as effective of care that we did for her.
Totally.
I didn't mean to send us down that rabbit hole. I really think that this is something that patients should be demanding at this point, as well as dentists should be providing. And I'll probably get in trouble from that from some of my dental colleagues, but I'm okay with that, because really we're at a point where that technology should be available to most of our patients. So
Really
with
simple.
that,
It's the bang for your buck on 3D is so
Yeah.
good. Yeah, the low radiation, low cost, exponential knowledge. It's so worth it.
Yeah.
all right, we have gone over, but it's only because there was so much good information here. Chad, would you like to close us out tonight?
Yeah, I'd be honored to. First of all, thank you, Dr. Walsh, for spending your evening with us. I know you've got nothing going on at home that you couldn't be attending to right now, but we certainly thank you for being here with us. I think that throughout this, I thought of another episode that we need to have, because one of the things I want to point out is we talked a lot about trauma, but I don't think we really gave the field of endodontics a true, I don't think we were able to shed it in the light that it deserved. I mean, Ryan, you did a fantastic job, but there's so much more to root canals than people really understand. And there's a lot of misinformation out there, in my opinion, that people need to understand that root canals are nothing to be fearful of, nor is the endodontist. They're actually something to be thankful for. So I'm thinking of another episode on, like, what is a root canal and what does an endodontist do? Because in our local community, we get a lot of questions about, I need a root canal. Who do I go to? And then the comments are like, oh, don't ever get a root canal. Don't do this. Don't do that. And, I think it's something that we all need to embrace and understand. Ryan, out of anybody that does root canals, treats trauma, does whatever, I know that you use the best products available. I know you've researched them extensively, and they're all very bio-friendly. And you just do such a fantastic job. So I want to thank you again for being here. Hope everybody got something out of trauma. Dr. Ryan Walsh, Keller, Texas. If you have any questions, reach out to us, and we'll certainly get the answers or get you in touch with Dr. Walsh. So thank you very much for your time, everybody, and hope y'all got something out of tonight, and we'll see you next week.
Before we close, Chad, do we have an email address where our listeners, if they have a question regarding the show, could?
Absolutely, we do. It's jhorowitzDMD@gmail.com. That's JHOROWITZ, D as in David, M as in Mary, D as in David, @gmail.com. Jeff will get back to you with an
Absolutely. You know what?
manner.
I have no problem with that. Just in the subject line, please put Dink's question. This way, if I see Dink's question in the subject line, I will answer it immediately. So
I would have never said that if I knew that Jeff wouldn't appreciate that, but you can email any of us. We'll actually, there's a way to get a hold of us, folks. Reach out to us through YouTube. We see all of the comments. And if you want to get in touch with us, with one of us personally or one of our guests, we will find a way for that to happen. Okay.
Just want to make sure they have an outlet if they have a question. That's all.
Absolutely. All right, everybody. Have a great
Have
night.
a great night.
Thanks, y'all.
Bye, everyone.
Bye.